important topic that you need to know. It's a thoracic or abdominal aortic aneurysm. Peripheral artery disease or peripheral vascular disease, when you have it everywhere. And the aorta is one of them, which run all the way down to the lower extremities as it branches. Okay, and so this is the heart, and it has 3 branches of supply vessels: brachiocephalic, cardiac, and subclavian. And then, so this is the heart, this is the ventricle, and this is the right atrium and the right ventricle. These vessels supply the upper portion of the body, so the head, the neck, and the upper extremities. And then the rest of the aorta goes down, and this is the thoracic portion of it. It goes down like that all the way into the abdomen, and it branches to the lower extremities. And if you put a diaphragm here, so the diaphragm, you put a diaphragm here like that, this become the thoracic portion, aorta, and this is the abdominal aorta. Unfortunately, these are vessels, and they can get into trouble. They can get something we call dilatation, which the fancy word is called aneurysm. Aneurysm is basically sac-like, like a sac-like dilatation of the vessel, basically. Remember, the blood vessel has 3 layers. So this is the actual lumen. This lumen is called the edema, the inside, and then this is the medial layer, and this is the adventitial layer. These are 3 layers of the blood vessel. And sometimes the layers can become like sac, they dilate. Or another word they usually use is outpouching. You have outpouching of the vessel, or dilatation. These are all fancy words, and that all come together to form what we call aneurysm. It's the same thing: sac-like dilatation, outpouching or dilatation of the vessel, and it develop what we call an aneurysm. I will explain to you what is the risk factors are. So when there's too much pressure, systemic vascular resistance, it affects the vessels, and then that causes a dilatation. You can have smoking. It's another risk factor. It's the same thing. High cholesterol, okay. Hyperlipidemia is a risk factor. If you are more than 65 years old, it's a risk factor. And of course, male cells. So if you're male and you're more than 65, you can develop aneurysm. That means as you get older and you're male, your male cells, and you're 65 years old, aneurysm is a risk factor. Age is a risk factor for patients like that. And so those are questions they can ask you. What are the risk factors for aneurysm? Yeah, those are the things you have to know. Smoking, and of course, sometimes you can prevent it. Family history is a risk factor. Family history, this, and age, you cannot modify it. But hypertension, smoking, hyperlipidemia, and lifestyle, those are modifying risk factors for the development of the aneurysm. So those are modified. So this can be a SATA question: what are the risk factors for the aneurysm? Hypertension, smoking, hyperlipidemia, age, and greater than 65. So what is the actual aneurysm? You have dilatation. So you see how smooth this is? Well, you have the 3 layers I talk about. Now, out pouches, same layer. So blood goes like that down the normal flow. But because of this aneurysm, you have blood going here, going. So there's too much pressure in the wall. And as you can see, sometimes this wall can rupture. Because of this, we'll talk about presentation. You can see there's turbulent flow in the sac. So there's too much blood going on in different directions. So you don't hear normal sound. The sound that you're going to hear is different, and we'll talk about it. So this is a simple explanation of the aneurysm and then what happened. And so this is what they have with risk factors. Because of that, this flow over here, usually you're going to hear a bruit because of turbulent flow, or you use a swishing sound or buzzing sound. So aneurysm will give a bruit or swishing sound or buzzing sound because of the turbulent flow. And this is just general idea of what aneurysm and the location. That's why we call one thoracic, the other one abdominal aortic aneurysm. So we'll start with the thoracic aneurysm. And the aorta, as you go down, it bulges out, and you develop this aneurysm. Call it. Other organs also there. You have the esophagus behind it. So you have esophagus behind it. You have the lung also there. So the lung is here like that. How will these people present? Think about it. Well, if the aneurysm get bigger, it pushes on esophagus. If something is pushing on your esophagus, well, you're going to have problems swallowing. You won't be able to swallow appropriately. There's a nerve that runs here like that. It's called vagus, and the recurrent is a laryngeal nerve that runs behind here and goes up. This involved in your voice. So if it's being pinched, you have hoarseness. So your voice changes. If the aneurysm pushes on the lung, you get shortness of breath. So you see, I think your exams is all pathophysiology. And everything we do is pathophysiology. You don't have to memorize. You just have to think and you know the underlying pathophysiology. If this aneurysm, whatever it pushes here, if it pushes on the trachea, whatever it pushes on, you're going to have symptoms. So if they give you a bunch of symptoms, you just have to know if this is in the chest and can it be related to the aneurysm pushing on something in the chest? Yeah. Then you can choose that as an answer. And so that's the presentation for normal presentation for patients who have thoracic aneurysm. The key one is swallowing, hoarseness, shortness of breath. There can be other symptoms. They can have pain, okay, at the back, depending on the presentation. What I want you to know is this aneurysm, because of this pressure, okay, going through the blood with the turbulent flow, they can rupture or do something we call dissection. Dissection means it can rupture, rupturing with blood trying to leak, but it's not completely leak. It's leaking into the wall slowly, slowly, slowly before a full rupture. So usually we call it a thoracic aneurysm dissection. How would that patient present? Look at it. You have an aneurysmal sac, large bulge in your chest that is leaking blood, where it will leak blood into the back of the chest. And so, but you're going to, because it's pushing on a bunch of things, and it is going to cause problem. So usually this happen, the best way this happen, it does not just happen. It comes with like deceleration injury. Like when you're driving and you stop your car right away and your chest hit the steering wheel. So usually that's what happens. Somebody is driving and the chest hit the steering wheel or fall from a height and hit the ground and then the aorta gets separated from the wall, and so they can have dissection. Patient usually present sudden, acute, and these are the keywords: tearing, ripping, chest pain. So you should focus on these words. These are buzzwords you should know. Acute, sudden onset of sudden onset of acute tearing chest pain that irradiate to the up to the back of the chest. That is a classic presentation of a thoracic aortic aneurysm. They have sudden onset, acute, ripping, tearing chest pain radiating towards the back. And then the patient, if they're able to make it to the hospital, yes, we can fix it. But if they can't make it to the hospital, that means the aneurysm completely ruptured and blood leaks and they die. So if you see this question on priority patient, which of the following will you see? And you see these buzzwords: sudden onset of tearing, ripping, chest pain, going to the back, you should pick that patient. That patient can die right away. And it's a priority patient that need treatment right away. What is the treatment? Think about it. Patient is having this pressure in the aneurysm that is causing the aneurysm to be rupturing. And if they present to the hospital, well, the number one thing you have to do is decrease their blood pressure so that there's less pressure in the sac, and then decrease their heart rate. So this is a priority. This is the first thing you want to do. You slow down the heart so that, because if the heart continues to pump blood, it will leak out and the patient die. And so lower their blood pressure to a normal, to a acceptable level that will still allow perfusion to the brain, and then lower their heart rate so that you slow down their heart. And usually we use a beta blocker to do that. So beta blocker is the treatment of choice for dissection aortic aneurysm. You want to lower their blood pressure, you want to lower their heart rate. And then they may need some fluid, so they may need an IV fluid. But you don't want to make their blood pressure too high, otherwise they will leak out. So usually we want to keep systolic like 100. So systolic blood pressure like 100, and blood pressure, the heart rate in the 70s to the 80s. Basically, you want to bring it down as much as you can, 70 to 80 range heart rate. So this is the treatment for a patient presenting with a dissecting thoracic aneurysm. They will need surgery depending on the location, but that is too much for you guys don't need to worry about. This is a summary of a thoracic aneurysm, the presentation, the symptoms, signs and symptoms, and the treatment. They are in your abdomen. So this is where it's located. Okay. And this is where it is in the abdomen. So the diaphragm is here. This is all in the abdomen. So what do you think is the presentation? You have this board sitting in the middle of your abdomen. Well, it's easy to feel it. Sometimes you see what we call palpable abdominal mass. So when you examine the patient, you feel a mass palpable in the abdomen. Yes. That's aortic aneurysm. Or sometimes it become pulsatile. If you put a stethoscope and you want to listen, you can hear a bruit. And the common place to hear it is on the left side of the belly button. So these are you can they present, or they have dissection like the thoracic. Their presentation will show acute also abdominal pain radiating to the back is a priority. Their blood pressure may be low because they will be in shock. We want to lower their heart rate to like 70 to 80 and give them some fluid and blood transfusion. So now that we know what they are, what are the symptoms, and what is the presentation, how do you repair it? Well, you can repair them with the open approach versus endovascular. What it means is open means you're making incision. So there's a big incision in the abdomen or chest. Endovascular means you're going through the groin. You're making tiny incision using needle and using contrast. Take a pictures with wires. You put a wire through the vessel and go to the aneurysm and repair it from there. So one is incision, the other one is a small, tiny incision. We don't even call it. It's just puncture wound in the groin to get to the vessel and fix it. Well, they're going through the chest. So this is your chest. They have to go through your chest. So your diaphragm will be here. So they go through your chest. So you have incision in your chest. So the incision is in the chest. You need a chest tube to drain any fluid or any air left. So they get a fluid, chest, and blood that is left in the chest. It's for the chest tube to drain it. Post-op, you should expect what to take care of this patient. They will ask you as a nurse, what are intervention? What do you expect? Well, I will monitor the chest tube output. I need to monitor the chest tube output. I need to check their pulses. You also have to monitor their urine output. Do, of course, pain management. When you have incision in the chest, well, you got to manage their pain. And then because they have incision in the chest, they won't be able to breathe well. So they need pulmonary toilet. So that is the chest. If you go into the abdomen, because it's an open in the abdomen, yes, they have incision in the abdomen, big incision. They will repair it, they will put the stent, and they will fix it. Okay? At the end of the procedure, post-op, okay, what do you expect? You have big incision in your abdomen. After they repair the aneurysm, what do you expect? Well, check their pulses. You still have to check their pulses. So you do neurovascular exams. 2, you need to check the incision. The incision can get infected. And so check the incision in the abdomen. You give them pain medication, okay? You should expect their bowel sounds to be decreased. So decrease bowel sounds when they have this big incision in the abdomen. Well, their bowel sounds will be decreased. Okay. Because of I told you I draw the kidney. The kidney is usually sit here like that. And these vessels that supply the kidney, when we fixing it, we clamp it. Either we go above it, we try to go below it and fix and clamp it so that no blood flow, so that a little bit of blood go to the kidney. But sometimes the kidney get into trouble. So you got to check their renal function. And how do you check renal function? Check their creatinine and their BUN. Or you check their intake and output, how much urine they making, checking the kidney function. And so these are starter questions, or these are pathophysiology, what you expect post-op, how do you manage them post-op. And number 1 is to make sure their pulses are intact. Let's talk about the endovascular. Okay, to fix this aneurysm, instead of making incision, they go into your groin and they're using a wire to come here like that and put a stent in it. Put a stent in it so that the artery will come straight and then blood doesn't go into this sac and the blood flow. There is no incision in the abdomen or chest. All you have is some puncture wounds in the groin. So after the procedure, post-op, what do? Well, you got to check the groin so that they don't develop hematoma, because you puncturing the vessel, so they will develop hematoma. So you got to check the groin. They have to lay flat for at least 6 hours. This is very key to prevent bleeding. So let them lay flat for 6 hours to prevent bleeding. Okay. If you don't do that, so, they're going to bleed. You also have to check pulses. It's very important. Check for pulses of the lower extremities. They can have blue toe or some ischemia of the toe. Is because the graft may be clot. They may clot up, or they may embolize some clot into the lower extremities. And that can happen. That's why you got to check their pulses in the lower extremities to make sure everything is fine. If you see blue toe, that means the graft is occluded. There's some key things you should remember. This is an endovascular repair. Sometimes they can get into trouble. So you should pay attention to that. What do you do with that? Usually they can bleed, okay? And when they bleed, how do they present? Both open and endovascular repair. When you repair them, they can bleed. But because the aorta is retroperitoneum, they won't present right away. You may see hypotension. You may see tachycardia. You may see Kellen sign. That means bruises around the belly button. You will see gray tenor sign, bruises in the flank area. These are all select apply question or knowledge-based question that you can think. I'm showing you how patient will present in being shock or bleeding after either open repair or endovascular repair, and they bleeding into the retroperitoneum. And so they have Kellen sign, flank, umbilical ecchymosis, gray tenor flank ecchymosis, increased heart rate, lower blood pressure, change in mental status. So these are all shock. They will start to have back pain, even though you repair the aneurysm. These are signs and symptoms of hemorrhage. They're leaking. And as you can see, it's a B-sharp issue, which is a priority patient. So if they present you with a priority patient who had endovascular repair with low blood pressure, high heart rate, Kellen sign, gray tenor sign, change in mental status, back pain after endovascular repair, you have to choose this patient as a priority. It's number one, unless there is an airway. That patient is hemorrhaging, and you should pay attention to that. So that is a priority patient. You should pay attention to that. So I have a patient for you. A client underwent open aortic aneurysm repair. So AAA means abdominal and aneurysm. If it's thoracic, they will tell you this is abdominal aneurysm. Which of the following prescription should the nurse expect? So the patient had a open aortic abdominal aortic aneurysm. Which prescription the nurse is expected? Basically, what do you expect as a nurse if somebody underwent open aortic abdominal aneurysm? Abdominal aortic aneurysm. Okay, one, check Q1 neurovascular check. Yes, you need to check the pulses is number one to make sure graft has not thrombosed. Straight out and hold. In I and O's, yes, you got to check their urine output and how much fluid you're giving them. Decrease bowel sounds in all four quadrants. They have open AAA. Yes, you have to do that because the bowel sounds is expected to decrease. So this is what the nurse expect to see. Their bowel sound is not going to be normal. Check groin for bleeding. You check the groin for endovascular, not for open aortic aneurysm. Pay attention. Endovascular repair, that's when you check groin. These people have incision in their abdomen. So if this is the abdomen, they have incision right there. So there's no need to check their groin. So this is wrong. Pain medication, of course. With this big incision, they need a pain medication. Chest tube to suction. This is a tricky one, even though it's a aneurysm, is not thoracic. If he said thoracic, yes, that's when you need chest tube. So you don't need chest tube. Back pain. They shouldn't have back pain. If they have back pain, that means they're leaking. So this is a tricky one. So the answer is 1, 2, 3, and 5. You see how I can, so this is me applying everything so that you guys can see how they can ask questions on that. So this is a multi-level question. I intentionally did it so that you can start thinking in the next gen area, how they can ask questions. And this is the idea. It also will help you as you study for this portion before next year. A client present with a sudden, sudden onset of tearing chest pain radiating to the back. Which of the following is a priority diagnosis? So I'm giving you questions so that you can think about it and make a diagnosis. You have to make a diagnosis sometimes, and that will help you answer questions. A client present with sudden onset of tearing chest pain. So you have 1, 2, radiating to the back, 3, which is a priority diagnosis. We talk about it. Sudden onset, tearing chest pain radiating to the back is not MI, it's not pulmonary embolism, it's a thoracic aortic aneurysm dissection, not abdominal aortic aneurysm. Abdomen will have sudden onset of abdominal pain radiating towards the back. So 3 is the right answer. So this is it's a multi-level question. So you go, now we know a patient has what? A thoracic aneurysm. What is the priority intervention? So if you have thoracic aneurysm, what is the priority intervention? Number 1 is to lower their blood pressure and heart rate. They will need a bolus of normal saline. They will need their blood pressure to be slowed down. They will need some fluid. By giving them bolus will increase their blood pressure more, and that will become a problem. They may need some fluid. Beta blocker to lower their blood pressure and heart rate. You want their blood pressure to be systolic of 100 and heart rate between 70 to 80. So this is the right answer. Transfuse 2 units. Yes, they need blood, but it's not a priority. Immediate surgery, they will need surgery, but it's not a priority. You want to lower their blood pressure and heart rate as a priority intervention. Priority intervention. The same question we're following. Which intervention should the nurse implement after endovascular repair? So the patient has thoracic aneurysm, okay? This is the heart, and this is the aneurysm, this is the diaphragm, so this is the heart. But we repair this, so we can repair both thoracic and abdomen with the endovascular. So we put a stent here like that, and we fix it. And usually you go through the groin. There is no incision in the chest. There's no incision in the abdomen. So what should you implement after this procedure? Monitor their chest tube. Well, you use chest tube if there is incision. Because we're going to the groin, we don't need to have chest tube in the chest. We did not go to the chest. So this is wrong. Monitor groin incision, yes. Because this is endovascular. That means we use a catheter to go through. High Fowler position. I told you we got to keep the patient flat for 6 hours. So this is wrong. Assess dorsal pedis pulses. Yes, whenever you do vascular procedure, check their pulses to make sure the vessel is not occluded. Assess bowel sounds. This is for AAA, abdominal aortic aneurysm. We were dealing with thoracic aneurysm, aortic aneurysm, TAA instead of AAA. So we're dealing with thoracic aortic aneurysm, not abdominal aortic aneurysm. So we don't need to check their bowel sound. Resume metformin immediately after surgery. Well, after the endovascular repair, if they are metformin, you wait for 48 hours. So the only answer is 2 and 4. Now, the same question, okay? I intentionally did it like that. Which of the, so that you can start thinking, with using the same idea, you know the diagnosis, we have 4 questions under that. Which of the following required HCP notification after endovascular repair? So the patient we're talking about as a TTA, TAA, thoracic aortic aneurysm. So which one will you call the ACP when you see after he has had a aneurysm repair? BUN of 45. Well, his renal function has gone down, so something is wrong. So you need to call. Urine output of 200 ml in 3 hours. Well, you need at least 30 cc an hour. So 30 cc, usually at least you need like 100 in 3 hours. Well, this patient had 200. So it's good. You don't need to call. Ecchymosis around the umbilicus. This is curling sign. But you see this when you are in the abdomen, not in the chest. It will be hard. Sometimes it depends on how big is the thoracic aneurysm. This can happen, but most of the time, and the fluid stay in the chest. The one I drew usually is possible. This is possible, depending on if they tell you where the aneurysm is located. It can transfer. It can go all the way down, but for now, we assume it's in the chest, so it's not the abdomen. Posterior tibia pulses +2. This is normal pulse, so I don't need to report it to the ACP. His heart rate is 120. He has endovascular repair of aneurysm. Now his heart rate is 120. That is shock. You should see my B sharp, this thing. Shock, if B sharp with S being shock, hypotension, tachycardia. So this you got to call. Systolic blood pressure of 100. This is okay for endovascular repair. The systolic blood pressure is okay. It's not that low. So this is fine. So it's 1 and 1, 2, 3, 4, 5.